All right, hi everybody. Today we have Dr. Hannah Peach. She works at the University of North Carolina in Charlotte and has a doctorate in philosophy of health psychology. It seems like also your undergrad and your master's are from North Carolina, South Carolina. So if there are any other Carolina folks here. And today we're going to hear about her research on sleep and wellness. So if you want to screen share, feel free. And if anything gets messy, just let me know.
Okay, let's see. So let me go ahead and see if I can share my screen. Okay, good. Can everybody see my screen? Okay, awesome. Well, hi, I'm Hannah Peach. I'm excited to be here and share a little bit with you about my research. So sleep is a humongous field, a super important field that's starting to get a lot of traction and a lot of attention, I think, in society as a whole. So I could talk for a whole semester about all of the cool things about sleep, but I wanted to hone in on sleep health. This is a little bit of a newer term in the health psychology field. So defining what this is, talking about why it's so important for health and wellness, my little ABCs of thinking of predictors or influences on sleep health, and then talking about some possible strategies that you could take from this presentation and apply it in your own life to improve your sleep health and have hopefully good cascading effects on your wellness. So one of the things I do when I teach, I teach a sleep and health seminar and I teach a health psych class. And I do this every semester with my students where I say, okay, I'm going to have you pretend we all know what sleep is, right? Before we can define sleep health, we want to figure out what sleep is. We know what it is, but I tell students, pretend that an alien from outer space came down to our planet and they don't have sleep in their species. How would you define or describe sleep? And I'm going to see, maybe we can do in the chat. Tell me, how would you define sleep? And I don't know if Eric or Sasha, if people put it in the chat, if you can share it, I don't think I can see it on my end. Okay, let's see, that popped up there. So a period of unconsciousness. Yeah, so the word consciousness is key here. Daily. Okay, so this idea of doing it on a regular basis. Oh, good. Say a reparative resting state. I like that. Physical and mental restoration. Okay, brain activity. So you guys hit some really, really good phrases that we're going to talk about. Okay, restorative state needed to survive. Yay. Okay, so you hit some major ones. You said restoration, daily, brain activity, reset. I love it. Okay, so we're getting there. So sleep is weird. Okay, so sleep is a very complex thing to define because we can capture it in multiple ways. We can first define sleep as a biological state. And some of you mentioned this idea of consciousness. We can also characterize it as a state of consciousness. And it's something that we have to engage in regularly in order to survive. And ways that we can measure if somebody has entered into this biological state is through a set of very particular physiological functions. And we can measure these physiological functions through something called polysomnography, which is a fancy word for an overnight sleep study. The person looks like a science experiment, and we get measures of these particular physiological functions that let us know which stage of sleep somebody has entered into. And we'll talk more about this in just a minute. So when somebody comes in for a PSG study, we stick leads all over them. We put leads on their head for an EEG so we can get measures of brainwave activity. We do an ECG on their chest to get heart rate. We stick leads all over them to get measures of muscle movement. And we also get airflow and measures of oxygen levels. So these different physiological functions will look like this when we measure it in through an overnight sleep study. So I'm not a sleep technician. I am fascinated by the training that these folks get because they can look at a screenshot like this of data that comes from a sleep study, and they can instantly say, oh, this is XYZ stage, because what we're looking at here are measures of those different physiological functions. So in the middle, we can see that red line, that's the ECG. So that's an actual measure of heart rate. We've got measures of eye movement up there at the top. We get measures of movement in their legs because we have leads on their legs. And this is really helpful in a variety of settings, right? We do this in research and we do this to diagnose sleep disorders. So all of this to sort of show this is how we know when somebody's entered into different biological states of sleep. We, over the years, through all of this research, have been able to understand the different stages of sleep that we enter into. And this is probably not new information for you. You've probably heard of REM and non-REM sleep. So we spend about 3/4 of a night of sleep in non-rapid eye movement sleep that we can then break down into 3 distinct stages. And then we spend about 25% of our time in REM sleep. So non-REM stage 1 is that stage, maybe if you're in a boring presentation or a class right after lunch, where you're kind of in between being awake and being alert and starting to fall asleep. So that's the one where you're maybe kind of leaning on your hand like this, your eyes are kind of opening and closing, you're paying less attention, but your muscles still active to keep your head upright. Stage 2 is when you fully committed, right? You've put your head all the way down on the desk, and it's getting harder to wake you up, right? The person sitting beside you can hear your breathing has sort of evened out. They're trying to poke you with a pencil to get you to wake up, and none of that seems to be working. We talked about those specific physiological functions that are characteristic of different sleep stages. And here what we see through an EEG are particular alpha waves that we saw in the previous stage, but they're now being disrupted by these very unique little patterns of brain waves called sleep spindles and K complexes, which if you ever seen kind of a picture of stage 2 sleep, sleep spindles are these tiny little squiggly kind of brain pattern or brainwave patterns, and then big kind of windy K complexes. So again, a sleep tech could look at that and say, okay, I'm seeing these changes in these alpha waves. I'm seeing them disrupted by these other small kind of brainwave patterns. We've entered into this stage 2. We then from stage 2 will enter into stage 3, which we call slow wave sleep. This is a really fascinating field. We see those alpha waves turn into these big, broad delta waves. And at this point, we call it deeper sleep because it's really hard at that point to wake somebody up. They are very, non-responsive or alert or aware of the outside world. This particular stage, and some folks said in the chat the words restorative, which I love because this, we believe, is the stage that's most important for restoration. So if somebody's experiencing disruptions to their slow wave sleep, they didn't get enough slow wave sleep, we feel it the next day in terms of having very low energy levels that weren't properly restored the night before. We also know that other types of functionality are restored during slow wave sleep. So our immune system is being restored during that stage. We see the release of particular hormones. So when we don't have enough slow wave sleep, we see how this negatively can impact our body. For example, if you've ever pulled an all-nighter or you weren't sleeping very much around maybe finals and you've gotten sick right after class is wrapped, that could have been because you weren't sleeping enough, your immune system was then suppressed, and you were more vulnerable to something like being exposed to some sort of virus. We'll talk a little bit about hormones in a little bit when we talk about weight management. And then that REM sleep that we enter into, which is the deepest stage, in that it's very challenging to wake somebody up. But we call this stage paradoxical sleep, because while it's really, really hard, we are in the least amount of consciousness, we see more brain activity occurring than we actually see while we're awake, which is absolutely fascinating. We see much more oxygen. We see really high levels of brain arousal, which has led researchers to say, well, what's going on during this biological state? And research suggests that during this stage, memory consolidation is occurring. So during this biological state, our brains are taking all of that information, right, that we learned or that we were exposed to during the day, and doing things like strengthening neural synapses between this new information and old memories, shuffling out information that we don't need. And what's fascinating about that is that this is also the stage where we tend to dream in. And there's tons of different theories about why we dream and what dreams are. But one of the theories is that dreaming is our experience of this memory consolidation brain activity. So if you've ever had a dream and it made total sense while you were dreaming, and then you woke up and you tried to explain it to somebody else, this theory sort of aligns with that, right? That maybe it doesn't make sense, but it was your experience, right? Of strengthening or connecting these different neural synapses. This is also interesting because in this particular stage, our muscles are paralyzed. And another theory is that this is from kind of an adaptive or evolutionary standpoint of if we're dreaming and experiencing some sort of, content, if we acted out that dream, we're running in our dream and we stand up and we run, or we're flailing around, that could be harmful to our survival. So our muscles, we learned from this kind of adaptive standpoint to paralyze our muscles while we had this particular experience. So hopefully helpful to kind of get a sense of this biological state. This is a way that we can define sleep. But sleep is also complex because it involves a behavior and a choice on our end to enter into that biological state to some extent. So it requires us to make a decision, I'm going to go to sleep, and to lay down or to be in some sort of position where that relaxation can occur. We close our eyes when we're trying to sleep, and then we enter into this biological state, or also a state of consciousness. It's consciousness in that we're seeing reduced alertness and awareness to our own cognitive processes, but also to the outside world. But it's unique from other reduced consciousness states like a coma, and that it's relatively easy to reverse through an alarm clock, or somebody shaking us awake, or throwing a bucket of water, or something like that. And as a student mentioned the word daily, we typically engage in this behavior on a daily basis for a continuous amount of time. So understanding what sleep is important before we can talk about sleep health, which again is a newer construct that we've defined in health psychology. And defining sleep health has followed the same logic as the way we now define health in general. So the outdated model, the biomedical model of health, used to define it as the absence of disease. So that was sort of the old way. And we found over time that was lacking, right? That wasn't comprehensive enough. In this particular model, we separated the mind and body, right? That any sort of physical ailments was separate from any sort of emotional processes, which we now know is completely false. And in this model, we reduced everything to having organic causes, some sort of chemical cause, which we now know is not enough, because we have lots of puzzling types of health problems with chronic diseases and whatnot. So through the new biopsychosocial model, we define health, so this World Health Organization definition of a state of complete physical, mental, and social well-being that permits us to lead socially and economically productive lives. So the word well-being is in there, right? It's not a total focus on disease, but rather looking holistically at wellness, right? There's that positive aspect, and considering the multiple different pieces. It's not just physical. We're also considering the mental and social aspects. I also love that this puts people within the larger social context, right? And that's going to be important when we think about sleep health. So traditionally, sleep medicine took that same sort of biomedical approach, and it was really focused on sleep disorders and sleep deficiency. So not getting enough sleep. This is still very important and something that I'll talk about today in this presentation, but we're also taking that positive spin of considering wellness. So a sleep health definition provided by Boise in a really important article, I think that I shared before the presentation, is that sleep health is multidimensional, which is important, right? Because we said we define sleep in multiple different ways. And that it's this concept of promoting physical and mental well-being. So sleep health. Again, because it's multidimensional, we can measure it and pay attention to different important components of sleep health. So one component is our subjective satisfaction. How do we feel about our sleep? Do I feel good? Do I feel that I get enough? Do I feel that I'm totally deflated? And what we have found in research is that my view of my sleep is an independent and strong predictor of lots of other health outcomes. So even if I have objectively measured through PSG the amount of hours I got of sleep or other sorts of characteristics, how I feel, how satisfied I am matters. Alertness. So this idea of how alert I feel during the day, how much energy do I have? We're going to talk about that. This is a really important aspect, right, of sleep health. And we know this anecdotally, right? We feel good. We're happier when we wake up and we've got that good restorative amount of energy that we've gotten from our slow wave sleep. Timing. So we'll talk today about sleep scheduling. Is the timing of my sleep appropriate? Am I awake at the times that I want or need to be awake? And when I want or need to be asleep, am I able to do that? And regular timing, regular scheduling will come into play there. Efficiency. Another word for this, or another term we see in health psych, is quality. Sleep quality. So do I see continuity of sleep? How long does it take me to fall asleep? Do I stay asleep? So having really high efficiency. We don't want to have a whole lot of sleep disruptions throughout our different sleep stages. And then duration, which is the one that we hear the most about, and sleep duration is really important. But again, it's not the only dimension of sleep health. And one thing I just wanted to point out really quickly when we talk about sleep duration is that we do have sort of national recommendations based on loads of research of how much we should be sleeping for optimal functioning at different stages of development. So you can see there in the right-hand side, for adults, 7 to 9, 7 to 8 hours is the recommended amount. There are always individual differences. I always have a student that comes up to me and says, I'm fine after 6 hours. And I said, maybe for your body, that's enough, right, for you to feel optimal functioning the next day. And what I want to point out with those recommendations there is that the younger we are, the more sleep we need. And if we think about what we just talked about with sleep staging, the restoration must occur during slow wave sleep, and the memory consolidation occurs during REM. Think about how much growth and learning occurs when we're little. Think about how much babies change in just 2 months or 6 months or a year, right? I have a nephew, and oh my gosh, in a year, he went from, babbling to we can't get him to stop talking, right? So sleep is obviously so important. It's not, there's causal. It's not just correlational that we spend all this time sleeping when we're younger and we see all this unbelievable growth and maturation and learning and memory. Good. So we have this idea of what sleep health is. So my next question is, well, why do we care? Why does it matter if we have good dimensions, right, of those 5 areas of sleep health? Well, we could have a whole semester on talking about why sleep matters. Sleep health is, and I know I'm biased because I'm a sleep researcher, but we have found that it's connected to virtually every other aspect of our wellness. And that when we don't have good sleep health, we see deficits that occur. So first of all, it impairs when we don't sleep well, it impairs our cognitive well-being. There's a lot of research that's connected sleep loss, particularly to the prefrontal cortex, which we know is really, really important for impulse control, for decision-making, being able to think about the future, weighing, short-term goals versus long-term goals. So this is very important, right, in our daily life to be able to make those good decisions. We mentioned how REM sleep is important for memory consolidation. So it makes perfect sense, right, that when we don't have enough REM sleep, it can impair memory, both short-term and long-term. So there's lots of experimental and correlational research to show that when we keep folks up all night long, right, those folks have worse short-term memory than those folks that are well rested. But we're also seeing across the lifespan connections between sleep, health, and memory. So there have been studies to show that folks that have had chronically poor sleep are at a higher risk for Alzheimer's disease. So we're starting to unpack and understand the neuroscience behind how and why this may be happening. We see other impacts of cognition being impaired. We tend to overestimate our abilities and our accuracy when we're sleep deprived. So we're really not good at judging our own abilities. And we see slower reaction times, right? So we've seen this through experimental research. When we're sleep deprived, if I'm responding to some sort of task, my response is much slower when I'm sleep deprived. And we can think about this sort of reflecting on ourselves of, well, how would that impact me in my daily life, right? In terms of my academic performance or my job performance. And again, there's lots of research connecting sleep duration to students' GPA and to lots of medical errors. We see sleep loss in medical errors. And one that I just wanted to show you that I thought was fascinating is an article that was looking at sleep and judgment, actually in judges. So what these folks did is pull data in terms of sentences that judges were doling out on just kind of regular parts of the year in comparison to the day after daylight savings, where everybody loses an hour of sleep. And what they found in this comparison is that after daylight savings, judges did in fact provide more severe sentences in comparison to other parts of the year. So I think a really interesting correlational, but really interesting outcome to see, right, of how judgment is impaired, right? And this has really big, important effects on society, right? And on these individuals within the support system. So physical well-being is another major area that sleep health is connected to. Weight management, that's been a really big one. That's a very lucrative field, right? Weight loss, and sleep plays a really big role in that. There's lots of theories for why sleep loss or poor sleep is related to the concept of managing weight or gaining weight. Would people be more susceptible to acting on bias? Super interesting. I've never looked particularly into sleep and bias, but I would suspect absolutely. We're going to talk in just a sec too about emotional well-being being impacted. So if we think about our cognition and decision-making is impaired, we're also seeing worse ability to regulate our emotions. I suspect that would interact and we would see more bias. I love that. Yeah, I would love to see if somebody looks up an article on that. Good. So with weight management, lots of theories of how sleep health relates to it. So I'm trying to keep an eye on the chat. Good. I love that. One of them is through energy levels. Pretty understandable one that when I'm sleep deprived, I'm going to be far less likely to want to go to the gym. I have less energy. We also think that there's some hormone related theories. So we mentioned during slow wave sleep that hormones are regulated and released. Leptin and ghrelin are two appetite related hormones. We're not getting enough slow wave sleep and those aren't being regulated properly. That can impact our ability to regulate our appetites and that we're eating a lot more than we need to. Heart health is also a really, this is an area I'm particularly interested in. I've looked at blood pressure and sleep a whole lot, and they're very strongly connected. So I mentioned during during slow wave, stage 2 is when we start to see that our body temperature lowers, and we also see that blood pressure will start to dip as we get into the deeper stages of sleep. So if we're getting a nice solid couple cycles of sleep staging, our blood pressure will dip during the deeper stages and come back up to a normal level. If we don't have enough, if we're not spending enough time in those sleep stages, our blood pressure doesn't dip the way it should, and so it's higher upon awakening. When we experience chronic sleep loss, we're going to start to experience chronically higher blood pressure, which is diagnosed as hypertension. Super bad for our heart health, right? We see folks with untreated hypertension are twice as likely to have a heart attack. It's also connected to other problems with our cardiovascular system, like stroke and heart disease. We've connected poor sleep health with accidents, lots of different type of accidents on the job. There have been, kind of international, national crises that have occurred because there were errors caused by sleep deprivation. A particular area that we've been studying is this concept of drowsy driving, right? Which is like it sounds, you're driving while you're sleep deprived. Research shows that drowsy driving is just as dangerous if not more so than drunk driving. And again, some of the things that we've talked about, we can understand why this happens. We have a slower reaction time. We're less alert. We're not making as good decisions. And if we're physically falling asleep at the wheel, right, that's a problem because we're not conscious enough, right, to be responding to the environment and the fact that we're driving, right, a moving vehicle. And then risky behavior. This is one area that I've studied in particular. Research shows that when we don't have good sleep health, we're more likely to make a host of different types of risky decisions. They've connected it to risky sex, substance abuse, alcohol use, and even in experimental settings. We see that folks that are sleep deprived are more likely to make risks in like gambling tasks. And so we can see how that would happen in an actual environment of making worse decisions. And that can impair our health in a lot of different ways. And so and these are just a few, right? We could go into lots of other specific areas of health that are impacted, but we can think how all of this together can have a cumulative impact on our lifespan. And research has in fact studied that specifically and found across longitudinal studies that dimensions of sleep health do predict mortality rates. So when we have worse dimensions of sleep health, that can predict having a shorter lifespan, which I think really highlights why sleep health is so important. And then emotional well-being. And with our great question about bias, cognitive, emotional, and physical well-being all sort of interconnect there. So these are interactive, right, and can be cumulative. With emotional well-being, I think anecdotally, right, we know that sleep is important for our emotional well-being, right? We feel crummy the day after not getting a good night of sleep. But we see from a clinical perspective that these issues can become morbid. So folks that have sleep problems a lot of times can experience either a higher risk for things like depression and anxiety or exacerbating the symptoms of them. When we think about depression, anxiety, and stress, there's a bi-directional relationship here with sleep. So if we think for ourselves, if we're really stressed out, right, maybe about our schoolwork, about our job, about our relationship, sometimes we have sleep problems, right? We're so stressed out and anxious and having a hard time relaxing that we don't sleep very well, right? It takes us a long time to fall asleep or to stay asleep. And then we wake up the next day, and because we're sleep deprived, it exacerbates, right, our stress. We don't have the cognitive and emotional resources to manage what's going on, right? So our stress gets worse, and then the stress affects our sleep, and it's this ongoing vicious cycle. As we mentioned before, we have fewer emotional resources when we're sleep deprived. So we feel more irritable, we're more fatigued, right? We might be more likely to be snappy. And we could think how when all of that comes together, that could impact our relationships. That could have an impact on our social well-being. And again, we've researched and found connections here. So this particular study was studying female college students, and they found that these individuals, when they were, more sleep deprived, were more likely to engage in aggressive behaviors towards their romantic partners, which again, very important to understand how sleep plays a role in our social well-being. So we've sort of looked at the second half of this formula. And this is sort of, this encapsulates everything that I study, right? Sometimes I want to hone in on the predictors, what's influencing sleep health. And sometimes I want to look at sleep health and say, well, what are the outcomes? So we've done that sort of second half. Now I want to look at the ABCs. So looking at these predictors of our sleep health. So I'm just a clever, I thought, acronym. So we'll talk about attitudinal predictors. We'll talk about behavioral predictors, and we'll talk about cognitive predictors. But I want to switch up the order a little bit just to sort of tell a little bit of a story here of which ones seem to have a greater impact. So just like with any health behavior, we always look at knowledge, right? So when we think about something like hypertension, because I study that, high blood pressure, it makes sense that if somebody knows what high blood pressure is, they know how to measure it, right? How to, either purchase a machine, right? And get that measure, or go to a CVS and use their equipment there. So we know how to measure it. We know factors that influence it, right? So sodium intake can impact our blood pressure. Stress impacts our blood pressure. So it makes sense that if we know all of this information, right, that we would be more likely to engage in activities that would keep our blood pressure low. So the concept makes sense. Same when it comes to sleep and sleep health. We can think about, okay, well, what do I know what sleep is? Do I know why sleep is important? Do I know the factors that play into promoting me getting good sleep health? Do I know what sleep disorders are? Do I know the symptoms? Do I know how to treat it? And the theory here is that if I know enough, then I will engage in the good behaviors. So there have been a lot of studies on sleep education programs. So a lot of work has gone into designing these education programs. What's the type of knowledge that we want to present, and evaluating, right? Did folks actually correctly master the content? And then looking to see, well, did it work, right? Do folks have better sleep health after being exposed to this information? And what we've at least found in our own research is that knowledge it's good, and it's a good idea, but it's not enough. That just because somebody knows what sleep health is, they understand why it's important, that does not translate into me being a better sleeper. At least in my research lab, what we have found is that attitudes is more important than knowledge. Attitudes, and I don't mean like if you have a bad attitude, but your attitude, your favorable or unfavorable evaluation of something. And we have studied attitudes. This is a huge field. So I started getting interested in this idea of attitudes when I was in grad school. And when I started to look it up, my gosh, there's all of these different theories about attitudes and behaviors. And it's been studied with so many different types of behaviors. So I've come across articles about attitudes towards flossing or brushing your teeth, attitudes towards exercising, towards treatment adherence, and certainly towards sleep as well. There's lots of theories, right, that include attitudes as a predictor. So something like the theory of planned behavior, if you've ever heard of that before. But when I started thinking about attitudes towards sleep, it got messy, right? Because again, sleep is such a complex construct. It's not just a simple health behavior like brushing your teeth. Not just a choice to brush your teeth. It's not just a choice to sleep. It's, again, like we said, a biological state, right? In addition to being a behavior and a choice. And sometimes even when we make the choice, I want to go to sleep, we can't. We're still experiencing issues entering into that biological state. So because of that, we reassessed the way that we were defining or conceptualizing attitudes. And you can see in the definition here, we really wanted to take into account this idea that there's multiple components. There's the cognitive piece, the affective piece, right, and behavioral components. And in the research that we've been doing in our lab with attitudes, for sleep, it is a really strong predictor. So folks that say, I prioritize sleep, it matters to me, I would choose sleep over other things, these are the folks that we see tend to have better sleep health. Oppositely, and I've studied this a lot in college students, folks that say, I'll sleep when I'm dead, YOLO, if I've got a really busy schedule, sleep's the first thing that I cut, I would choose socializing over sleep. Those folks that have that type of attitude are the ones that are having shorter sleep durations, worse sleep quality, less satisfaction with their sleep. And then behavioral predictors. We talked about sleep health, right? Kind of encompasses a behavior, but then there's behaviors that sort of come before that. So I want to talk about the sort of the positive and negative things. So the things we want to avoid doing and the behaviors that we want to promote. So then I sort of wanted to break this down into two areas. The first is this idea, because again, sleep disorders are important. There are lots of people who they're doing the right things, they want to sleep and they can't. So a huge area of sleep health is understanding, right, the different types of sleep disorders, being aware, preventing them where possible, or treating them if those sleep disorders exist. So I'm going to talk in a little bit about some of the most common ones, and activities that we can engage in terms of recognizing or treating. So again, the kind of the negative, right? If we have a sleep disorder, that negatively impacts our sleep health. But then we also think about the positive aspect, right? This concept of sleep hygiene. So that may be a new term for you that you've never heard that particular phrase, but sleep hygiene is a phrase that describes the behaviors or the practices that we can engage in during the day or right before bed that promote those really good dimensions of sleep health. So good, sufficient sleep quantity, enough hours of sleep at night, really good sleep quality or high efficiency, and feeling really alert and energized during the day following our sleep. So these behavioral predictors, I kind of want to think about these and talk about some applications. So what can we do with this research to better our own lives, improve our own sleep health, and hopefully have those good effects on all the different areas of our well-being? So I mentioned just a minute ago, sleep hygiene. So those practices that we engage in during the day that promote good sleep health. And researchers have broken down sleep hygiene into kind of 4 primary domains. So the first one is arousal-related behaviors. So it makes sense. We all sleep, and we all know that when we're relaxed right before bed, that it's much easier for us to fall asleep. So it just makes sense, right? Common sense that we don't want to be engaging in any type of behavior before bed that's going to increase arousal, which makes it harder to relax. So things like racking your brain about a new paper that you're writing for a class or for publication, getting in a heated debate with a roommate. But what we've really focused on for the last decade is this idea of screen time before bed as an arousal related behavior. And there's 2 components of it. So this could be somebody who's laying in bed in the darkness with their phone right in front of them. They're typing away on their laptop or they're watching TV. First piece is that typically when you're in front of a screen, you're engaging in an arousal related behavior. You're watching, some horror movie. You are furiously working on your math homework. You're stalking your ex, right, on their Instagram. So that's going to make it harder to relax if you're doing that up until bedtime. The second piece of screen time is the light. So your circadian rhythm, right, which is your body's natural biological clock, from an evolutionary standpoint, is linked to light, right? So before we had artificial light, when it was light out, the sun was out and shining, we were awake. And when it was dark, we were asleep. Again, lots of theories behind that. It could have been that we were less susceptible to predators, right, at night that we couldn't see if we were still and we were quiet. But our bodies still function typically on that circadian rhythm. So when we introduce artificial light into the mix, that can be problematic for our circadian rhythm. So research has suggested that blue light in particular that comes from a screen, I did see an article that started to challenge that, but there is a body of research that suggests the blue light in particular, when received right through our retina, it goes up to our suprachiasmatic nucleus and it tells our body, oh, okay, light, it's time to be awake. Right? It blocks melatonin, which is important for kind of increasing being tired and falling asleep, and it affects our circadian rhythm. So if we're sitting here in the darkness in front of our little phones, and then we put it away and say, okay, it's time to sleep, our body's like, no way, it's time to party, right? So even if we want to sleep and there's a choice there, in terms of falling into that biological state, we've now messed up our circadian rhythm. So no screens is what the recommendation is, 30 minutes to an hour before bed. There are also blue light blocking glasses and some folks will actually do that during the day as well. That can reduce things like headaches from being in front of a screen. So there's some research on that, but the gold standard is to stay away from screens 30 minutes to an hour before bed. Sleep scheduling is the second domain of sleep hygiene. So our bodies crave homeostasis, right? We do best when we have regularity. Oh, even placebo. I love that. That'd be another interesting one to have 3 sort of experimental groups there. So sleep scheduling, going to bed and waking up at the exact time or about the exact time best for our circadian rhythm. That's challenging to do. right? I know, at least for me, when I'm on the weekends, I want to sleep in, I want to have that more kind of lazy morning. But according to the research, to promote our best sleep health, we want to do our best to go to bed and to wake up at the same time each day, whether it's weekday or weekend. So that's a pretty simple one, but it's actually challenging to do that when we think about all of the environmental demands that we have. Eating and drinking behaviors. So some of these are kind of we know, right? We want to avoid things like caffeine before bed. A lot of times we think of coffee or energy drinks. We also want to avoid caffeine in particular foods like chocolate. We don't want to have a massive meal before bed or go to bed hungry. That can also impact our sleep. Drinking alcohol is one that has been studied a lot. There's a myth, I think, sometimes where folks think that alcohol will help them fall asleep faster, but research shows that it's while you may feel like you're falling asleep faster, alcohol fragments are deeper stages of sleep. So even if you're sleeping or in bed for 7 to 9 hours, you're having really low sleep efficiency, and probably you're having low energy the next day, tired because that alcohol was impacting your sleep staging. And then our sleep environment. So the rule of thumb, again, there's individual differences and preferences, but the rule of thumb is to sleep in a cold, quiet, dark, comfy environment. That's the goal. And researchers suggest that your bed should only be used, the rule of thumb is for sleep or for sex. And this plays into this idea of screens, right? That your bed that should be your kind of safe place for sleeping. And I want to use the idea of classical conditioning to explain why we don't want to have a TV in the bedroom. So I'm sure we all remember from intro psych, Pavlov and his dogs, right? He was the one that studied classical conditioning. And what Pavlov did was condition these dogs to salivate at the sound of a bell. So by pairing the bell with food, which a dog would naturally salivate, right, at having food in front of him or her, by pairing that repeatedly, the dogs were conditioned to just hear the bell and they would start to salivate. The exact same thing can happen when we watch TV or movies in bed. So if you love to lay in bed and watch Game of Thrones, which I've never seen, but I've heard, wow, there's a lot going on in that show, and that would be very arousal related behaviors, right, of watching that show. Well, if you watch Game of Thrones in bed, your body starts to get conditioned to being alert and awake to watch the show. But then if you get into that same bed, that same environment, and you've removed Game of Thrones, your body still goes into that more alert or aroused state. So that's why we say it's really important to protect your bed. You don't want to lay in bed and study. You don't want to lay in bed with your computer, right? We want us to really save that for your sleep. The second piece here in terms of applying this, right, to improve our own sleep health is this idea of being aware and potentially treating sleep disorders. It's really important here when we think about hoping everybody gets an annual physical, because that's how we check in and try to catch these things. So one, it's really important for us to be a partner in our health and sharing with our provider any sort of symptoms or concerns that we have. And to be able to do that, we have to be aware of some of the most common sleep disorders. So the first one is sleep disordered breathing, also called sleep apnea. And what happens to somebody who has this disorder is they actually stop breathing during their sleep. So we have to have our airway nice and open, right, in order for us to take breaths and to pull oxygen into our lungs, to pull into our cardiovascular system, and to send that oxygen, right, to all of our organs. If our airway is partially or totally obstructed, the good news is that our bodies, our brains are very smart. So if we're sleeping and we start to experience partial or full obstruction, our brain goes, oh my gosh, we're not getting enough oxygen. We need to wake up. So I'll pause here and look. Morgan had a great question. So marijuana use and sleep health. We're starting to see more research on this area because it's being legalized in so many states. Research was a bit more limited previously because you were talking about illicit drug use, which is just always harder to measure, right? When we're talking about some sort of sensitive or illegal behavior. Morgan, the research I've seen is mixed. Some of the research talks about how folks find it easier to fall asleep with marijuana use, but I have seen a couple of studies that suggest that it could impair sleep staging later in the night. So I actually had a colleague who is amazing and an orthodontist and does a lot with dental sleep health. And he made a joke about some of this research. And he was like, yeah, you just wake up in the middle of the night and smoke a doobie and go back to sleep and it's fine, which is not what I'm recommending. But I think the research is a little mixed. Yes, variation, strain, brain-related impact, absolutely. Which is actually, if we think about the economic impact here, if you're in a state that's where it's legalized, maybe like Colorado, that could be a focus, right? Of having a strain that's you know, they're trying to have that particular impact of sleep, right? Of improving sleep. So very cool, very interesting. Love that. Okay, so, and coming back to sleep disordered breathing. So I would think I was saying that our bodies are so smart, our brains are so smart that it goes, Mayday, I'm not getting enough oxygen, wake up, right? And so you wake up right out of that stage of sleep and you start breathing normally. Most people, well, a lot of people don't even know that they stop breathing during their sleep. And especially if they don't even know that this sleep disorder exists. So some symptoms of sleep disordered breathing or sleep apnea are if somebody is in bed for a reasonable amount of time, 7 to 9 hours, but they always wake up feeling tired, right? They always wake up feeling tired, even when they've been in bed for 9 hours. Another possible symptom can be snoring. So snoring sometimes, and it's interesting to me, this does come back to education, can be important. A student one time said to me, I thought snoring was indicative of good sleep. And even in this little, sometimes we have kind of symbols, right, that would represent snoring. A lot of times snoring can be indicative of sleep disordered breathing. It's that the difficulty, the sound of difficulty of airway coming through. Not always, though. You have people who have sleep apnea and don't snore. You have people who snore and don't have sleep apnea. So it can be one. Recommendation for sleepwalking or talking. So sleepwalking or talking is, it's called a parasomnia. So that's a category of sleep disorders where basically weird stuff happens during your sleep. I don't personally know any. There's maybe some medications that physicians can provide. I don't know of any behavioral ones other than just for safety of something like somebody locking their door, right? Or something like that. There was a parasomnia where people get up and eat in the middle of the night. It's not very common, but people do weird stuff in their sleep. So parasomnia, not my area of expertise, but you could see maybe if talking to your doctor, if there are common recommendations. Good question. So with sleep disordered breathing, right, kind of knowing the symptoms of it, being very tired, the good thing, even though sleep disordered breathing is probably one of the most common sleep disorders, it can be the most dangerous. So people with untreated sleep apnea are twice as likely to have a heart attack because sleep deprivation is so linked, right, to blood pressure. But the good news is it's very treatable, very, very treatable. I think I saw something come through in the chat. Psychotherapy, so that's interesting. Stand-up special sleepwalk. Oh, interesting. By Mike, discusses severe. Oh, I'll have to look for that. I'm going to write that down right before we leave the meeting. Thank you for sharing that. Very cool. Very cool. So CPAP is it's typically the first treatment that's offered. CPAP stands for continuous positive airway pressure. And they've come a long way, these devices. They used to look like these Darth Vader kind of masks. They're a lot sleeker now, but it's basically a mask that you wear over your mouth and your nose that blows air into your airway and pops it open like a balloon, right? So it solves the problem just like that by keeping that airway open all night long. Oral appliances are less probably commonly known, definitely less commonly provided as a treatment. This is a dental appliance. So it looks like a mouth guard, maybe like you'd wear in sports, and it is fit and titrated by a dentist. And what it does is it manually pulls your jawway, so your lower jaw forward. And what that does is manually open your airway. And wearing that appliance all night will keep your airway open all night. Weight loss is sometimes also prescribed. So if you think about your airway partially or fully closing, we talked about during REM sleep, we experience muscle paralysis. So these muscles start to paralyze, right? So they're not keeping that airway open. If you have more weight, whether that's fat or even muscle, right, it's going to close the airway. We've seen that linemen, so we've studied this in NFL football players. We've seen this, I did a study years ago in college football players, our linemen, right? And our football players in those positions that really value bulk, right? For performance, those folks are at a greater risk for sleep apnea than other types of athletes or the general population because they have such thick necks. So weight loss sometimes can be prescribed. For some folks, weight loss is enough, right? If they lose enough weight and they lose that fat around their neck, the sleep apnea resolves itself. Circadian rhythm disorder is another kind of more common sleep disorder. This basically is where your natural circadian rhythm has a mismatch with your environmental demands. So this could be somebody who has a very typical circadian rhythm, wanting to be awake during the day and asleep at night, but they work third shift as a nurse, right? Or sometimes we have people who and people vary in their circadian rhythms. I tend to have a more delayed circadian rhythm in comparison to some other people. I usually teach classes a little bit later in the morning, but sometimes that's a problem, right? And we have to have some sort of treatment to make sure that our environmental demands, if we can't fix those, match our circadian rhythm. So light therapy sometimes is used, which is this kind of special lamp that a provider would prescribe to you and have you sit in front of or near that lamp at particular times throughout the day with the purpose of resetting your circadian rhythm to match your environmental demands. And then insomnia, which is a very messy diagnosis. Insomnia is basically chronic difficulty falling or staying asleep. Insomnia is very comorbid with stress and anxiety. So again, this can sort of be challenging in terms of a diagnosis. Sometimes the underlying cause could be stress and anxiety, but this is an important disorder to treat, right, clinically. So folks that have been diagnosed, medication is used a lot. So something like benzodiazepines may be prescribed. This can help with relaxation, reducing anxiety. There are other types of medications like Ambien and Lunesta that can work really, really well for folks, helping them fall asleep quickly and stay asleep. There's melatonin receptor agonists that can help. And then there's other kind of over-the-counter herbal supplements that for some people really seem to work, and there's some research behind it. For our benzos and some of these other sleep meds, they work, but we do have to be careful of dependency, of other side effects. So this can be fantastic, but we always want to be careful, right, when we're talking about pharmaceuticals. Cognitive behavioral therapy, we talk about this all the time in health psychology. This is a really versatile therapy that can be used for lots of different desired outcomes. And it's kind of a cafeteria approach, right, where you've got lots of different types of cognitive and behavioral strategies that we can choose from. We usually want the patient to play a very active role in selecting which treatments work best for them. Sometimes it's trying out multiple, using several at a time. Some of my favorites, progressive muscle relaxation. If you've ever heard of this before, when we talk about positive psychology in one of my classes, we actually do this as a class and it's kind of fun. You can Google it, you can YouTube it and find a video. It's typically somebody that's guiding you through it. So you're going to hear a voice, or if it's up on the screen, if it's YouTube or something, but it's going to involve you closing your eyes. You're listening to this very soothing voice. A lot of times there's very soothing background music, and this person is guiding you through each kind of major muscle of your body and having you focus in on it, tense that muscle up, and then release it. So it might focus on your forehead, your jaw, take you down to your shoulders, etc. And while you're doing this, going from your head all the way to your toes, you have focused in and purposefully relaxed every single muscle. So you've melted away any physical tension. And it also has this really relaxing impact right on your cognition. So this can be a really great tool before bed to promote relaxation. Lots of different breathing strategies that folks can engage in to reduce stress, reduce anxiety. That can be throughout the day, but certainly before sleep. Guided imagery. Oh, I love these. They're similar to PMR in that it's this really soothing kind of guide, but there's no focus on the physical body. It's going to be some sort of story that you're listening to that's going to be very relaxing. I've heard some of, you're walking along the beach and your feet are touching the soft sand and there's the sound of the waves lapping in. So it really is promoting that relaxation. And then mindfulness meditation, this area has exploded in health psychology, really putting some empirical evidence behind a lot of complementary and alternative medicine that's been, utilized for centuries, right, in a lot of Eastern cultures. Oh, so Brandon asked about naps. Naps are messy research. There's a lot of research on naps and folks always want to ask, and it's messy. So, and I know people hate this answer. It depends, right? It depends. There's different types of naps. There are naps people take in preparation for sleep loss, naps people take after sleep loss, and then habitual napping. There is research to suggest that as little as 5-minute naps. I don't even know how that's possible. That can have benefits. The rule of thumb typically is that you don't want to be sleeping more than one sleep cycle, right? So if you're sleeping into multiple sleep cycles, that's going to make it harder for you to fall asleep at night. The best rule of thumb that I've seen is that naps are most beneficial for habitual nappers. So if you're the kind of person you nap every day, that seems to be best. I don't know much about sound. Yeah, you're welcome, Brandon. I don't know much about sound therapy, Melissa, to be honest, to play into sleep habits. That could be one that maybe we look up as well. And again, that's what's so cool, in my opinion, so cool about sleep health is you can connect it to so many different areas. And what's really fun for me whenever I teach a sleep and health seminar is I give my students topics and I say, go out to the world and come back with information. And so I learn, and they introduce me to some really cool articles that I wouldn't have found on my own. So good questions. So CBT, and then I was talking about meditation, another kind of strategy that's been studied before. So with nappers, they have to have 7 to 9 total. Again, that kind of depends. Some folks need more sleep. So even if they're getting 7 to 9 at night, they might be getting another hour to nap. I've had people ask me before about cultures or species that sleep smaller amounts throughout a 24-hour period versus a continuous 7 to 9. I don't know much about that. I haven't seen research that suggests that that would be better. The concept of having consecutive back-to-back sleep stages or cycles of sleep stages is important because when we get into more sleep cycles, we spend more and more time in REM sleep. So that suggests that having that consecutive 7 to 9 hours is really important versus having a 2-hour nap and then 6 hours at night. So does that make sense? So I think the answer is it depends. Cultural differences to approaches. Very, very good question. So does the evening siesta in Europe lead to better school performance, productivity, quality of life? So to my knowledge, again, naps is not something that works universally for everybody. My thought on this concept of a cultural difference with a siesta, for example, is not the siesta itself. It's the cultural perspective of work-life balance, right? Of not being available 24/7. There is so much research to show, right, that I mean, everybody makes fun of us as America, right? We've got horrible health, even though we're one of the richest countries. And it's because of the way that we perceive health and we perceive the work-life balance. We are so go, go, go. We are sicker. We don't take vacations. We don't listen to our bodies, right? And not work when we need to take rest. So my answer to that would be, I don't think it's the nap as much as I'd love to give sleep the credit, it's not the nap in and of itself. It's the total cultural perspective of wellness and how much they value wellness that leads to things like less burnout, more productivity, and a higher quality of life. So that would be my take on that. Good, cool questions. I think well, so let me pull in a little bit here with culture. So in West Africa, most people take naps as the norm, and apparently something to do with the heat. Oh, that's so interesting that who else was I talking to recently? Somebody that maybe lived in Mexico. I can't remember, but they were saying the exact same thing about in their culture. It's related to the weather, right, of their agreement. That's so interesting. And your Spanish descent and life is enjoyed so much more over there. It is just unbelievable. And, it comes into the culture of sleep even here. I talk about this a lot with my students and even with faculty, right? We hear this idea of wearing sleep deprivation as a badge of honor. Like, oh, I only slept 5 hours because I worked so hard on my paper, right? And that's not beneficial. So it might speak to the cold temperature recommendation for better sleep. Yes, absolutely. Yep, temperature certainly plays a role there. And there's a podcast, interesting. The mandated 2-hour French lunch. So we all want to move to France. Is that what you're telling me? I love that. Well, this idea of culture. So you kind of beautifully led into my sort of last piece here of thinking about sleep and how to promote sleep health beyond the individual, right? There's things we can do to promote it for ourselves, but we need to think about this on a more national or global level. So you guys just pointed out a really good one. We need a total cultural shift, right? In the way that we're viewing sleep and the way that we view work-life balance. So that's definitely one. That's a really big task. And that's hard to actually, put into to more bite-sized steps. Some other things that we can possibly do. So if you read the Barnes article, really fantastic suggestions on policy implications. One of them is national standards for school start times. And this one is very close to my heart. So there is a lot of research to show that teenagers have a delayed circadian rhythm. So with the hormonal changes and all of this that occur during puberty, teenagers don't get tired until later in the night. And you might remember this from being in middle school or high school, right? That you're not getting tired until, let's see, 10. Yeah, so if somebody posts the name of the humorous sleep study again, that would be great. And maybe that's something too, Eric and Sasha, we can send some of this out afterwards. So good. So during puberty, when we're in our teens, if you remember, you probably didn't get tired until later in the night, right? Maybe 11, 12, 1 o'clock. Your body just isn't ready for you to fall asleep. Well, that's really problematic when your circadian rhythm, again, is mismatched to your environmental demands. I know when I was in high school, we had to go to school at 7:30 in the morning. So if I'm not falling asleep until midnight and I have to be up at 6 or 6:30, I'm getting a very short amount of sleep. So there has been a lot of recommendations that come out of research really pushing to have later school start times. So if high schools are starting at 9:30, this is matching up, right, to these sort of biological states, right, of the circadian rhythms of these teenagers. So my high school actually did change way after I was in school to a later start time. And so I partnered with our school to try to quickly collect pre and post data from the time change. We collected data from teachers and from students, and ours was a little bit more qualitative. We did see some reports of really positive changes from teachers and students, but then there's been other really big, really great studies that have found reductions in everything from suspensions, right? If coming back to this idea of risky behaviors, of our emotion regulation, right? So we saw lower suspensions, we saw better performance in the classrooms, folks were happier, they had more energy, right? So this could be one area where we could really promote sleep health on a national level. Better regulations for work schedules, right? So the transportation industry has really done a great job of this. So if we think about truck drivers, right, or pilots, there are regulations put in place, where a truck driver can only drive X amount of hours in a 24-hour period, right? Within their rules, you are not allowed to drive more than X amount. What I also think is interesting about this industry, and this came out of a conversation with a student years ago, for truck drivers that are diagnosed with sleep apnea, there is a chip that is put on their CPAP machine that takes measures of how many hours the CPAP was in use. And you have to have X amount of hours measured, right? And that information is shared back with the employer in order to be able to drive the next day. Same with pilots as well, right? So thinking about with these airlines, pilots can only fly X amount of hours in a 24-hour period. Think about if we took that concept and we applied it in other areas. I know, so I was talking to my aunt, I was in Colorado earlier in the summer, and she's a nurse, and she was telling me about when they shifted from 8-hour shifts to 12-hour. And she was explaining that change in and of itself was really beneficial for trying to have more regulation. So somebody wasn't working the first 8-hour shift one day and 2 days later the second, right? So yep, I'm absolutely going to stick around. So, and I promise I'm almost done with my presentation. So this is just an area where we could see a lot more work being done for regulation, right? So if folks have regular schedules, right, then their sleep schedule can also be more regular. There's been debate about eliminating daylight savings, right? Getting rid of it altogether. That has a huge disruption, right? Where our sleep schedules changed a whole hour, which is a big deal, right? When we think about how long it takes for our body to have to shift and adjust to this new environmental demand. So we would have less severe punishments or sentences from judges, we learned right in our article. So that's a potential area. And then changes in the healthcare system, which is extremely hard to do. I'm a little biased because I work with sleep apnea. I've worked particularly with veterans with sleep apnea and have learned through the VA system that CPAP is always what's provided in a lot of VA centers. Oral appliances aren't even an option. It's not even something that they tell the patients about. It's never discussed, which is problematic because CPAP has a much lower adherence rate. CPAP can be cumbersome. It can be uncomfortable. It can affect somebody's sex life. And veterans in particular can have CPAP claustrophobia. And it's really, really uncomfortable. There's anxiety involved. So an oral appliance could be a much better treatment option. I also will say I have bias with this concept of big pharma that runs a lot of the decision making in our healthcare field. I'm a huge proponent of trying behavioral approaches first. Looking to evidence-based complementary and alternative medicine, and then having a prevention approach, which that's a big, a big wishful thinking in America. But rather than treating the problem, how do we get to the beginning and try to prevent this from occurring? Focusing on things like weight management before sleep apnea occurs, those sorts of areas. So I think that took me to wanted to chat. You guys did a really good job of kind of chatting with me throughout. So if there's time, can we open up and folks can ask more questions? Thank you too for being here.
Thanks, Dr. Peach. We oftentimes want to think about what is our takeaways and our applications. Many of us are counselors, some researchers, some faculty. So I think I'm curious to hear what folks are taking away. And as you all collect your thoughts, I did have one question. You mentioned the perception of sleep being perhaps a better predictor of actual biological measurement of sleep. So what would be sort of some practical takeaways as you think about a counselor working with someone who's struggling with sleep? Should they focus on the behavior of sleep, or perhaps is there some attitudinal work that could help?
I think that's a great question. So I want to compare it really quickly to this idea of socioeconomic status. So research has shown that subjective SES is a better predictor of outcomes than objective. So it's not good to be in poverty, but it's worse to feel like you're in poverty. So I would say there, when we're thinking about attitudinal shifts of the value of sleep, and I think it comes back to this cultural perspective where sleep is a luxury. So I would say kind of in a clinical setting, one thing to do could be to promote for patients or for clients that sleep doesn't make them lazy, right? Sleep is a way to treat your body in a wonderful way. It's like eating vegetables. It's like exercising. You're doing something so wonderful for you. And I think that comes to sort of self-care. Sleep is a self-care. So for a mom, a busy mom, or you've got all these other things, by valuing sleep and having this attitude of this is not a luxury, this is a necessity, this is something I need to give my body every single night for 8 hours, it makes you a better person, right? It makes you healthier, it makes you more patient the next day, maybe with kids, it makes you better at your doing it as. So I have my colleagues that they're kind of, they work more in the industry, and they were talking about with their little ones, they talk about sleep as a superpower, right, with their younger patients. And I love that idea, right, that it gives us a superpower. It's a resource that isn't something that we should feel guilty about, right? Yeah, good thought.
Thanks, Dr. Peach, for your presentation. I work mostly with college students, so trying to get them to sleep is the worst. And they have the worst attitudes about sleep. So I really love being armed with research like you can improve your GPA with this sleep, or it really kind of shifts attitudinally for them when I talk about memory consolidation in particular. It's like you are going to school to learn things, and yet you're like compromising the one thing that actually makes the way I phrase it to them, and let me know how accurate this is it's the time in our brain where we move things from short-term memory to long-term memory. Exactly. I don't know how accurate that is, but that's what I tell them.
And I think that's a good general description, right? If they, it's like when they pull all-nighters. If you've got all of the stuff you've been quote unquote learning, it just sits up here. It doesn't actually get to seep in and make those connections where they're going to remember it the next day or a week from now. So I say the exact same thing to my students, and I, not that they maybe all care about data, but I quote, these studies, and I say the students that are the most successful are the ones that get the regular sleep, got the higher GPA. And I tell them, if you have to choose between writing more of a paper or studying more and going to sleep, always choose the sleep. Always choose the sleep. You're going to perform better. So, and I think the same thing, Kate, my students, just hearing them, the way they talk about sleep, I go, oh my goodness, it's just, it's such an attitude of.
And I wonder, and maybe you can answer this, if they seem to be, they can rebound faster than like I can at 30 now. It's just not possible for me anymore to rebound the way that they do.
Yeah.
And I think that affects their attitudes on sleep because they really feel like they can go without it.
And the other challenge with college students is that they have part of it, I want to say, is not their fault, in that their Monday, Wednesday can look totally different from their Tuesday, Thursday, which sets them up with more barriers of having a regular sleep schedule. They're also faced with, the cultural piece of, and I always make a joke when I put up the theory of planned behavior, and I put the model up, and I talk about how my roommate in college, her nickname was literally Lunesta, because she would nap all that. She valued sleep. And so I was like, okay, it's 11:30, it's 12 o'clock. I'm coming home from this party to get my 9 hours. It was normal. It was normalized. Subjective norms are a huge piece. And the subjective norm on a college campus is not that sleep is valued. So I think that's, and students also have a misconception that they can make up their sleep. Right? They say, well, I'm going to stay up for these couple of nights, but I'll catch up on my sleep on the weekend. And that's biologically impossible, right? You can't really.
So is that something that I can like be pretty firm about with them? It's like, that's not how not how this works.
It's not how it works. Exactly. Let's see. I saw something in the chat that came through. Let's see. From a faculty perspective, thinking about workload. Oh my gosh, yes. Holy moly, that's so true.
Yeah, you were talking about school policy, and I was thinking of it, because we're talking about college students, and I'm a faculty, so I'm always thinking about workload. And there's national policy on how much workload you should do as a student per credit hour. And actually that stems from students suing their university because of faculty not showing up for class and just not doing anything. So it's this weird kind of paradox that we exist within right now, where I think many of us would probably prefer to do less or assign less. So I think that's something important for me to reflect on as a faculty too, is I would much rather you take an extra hour of sleep than spend an extra hour in an assignment, because I think the learning would be better.
Mhm.
Your grade on the assignment might not be better, but I think the learning would be better.
Mhm.
You know, so Kate, I'm going to send you all kinds of advocacy vibes for your university so that you can help faculty conceptualize this perhaps a little bit differently. And Melissa, I see you itching to get in the conversation.
Yeah, so I wanted to go back a little bit, to what you were saying earlier in your presentation, because you were talking about, stress leads to less sleep leads to stress. And I think we get stuck in this idea of the cycle, when in reality, to me, as a practitioner, it's not just a cycle, it's a ripple. And what happens, because if you understand it as a ripple, anxiety leads to possibly, conflict in relationship and other things. And so as practitioners, we may be way out here on this outer circle of the ripple, trying to help the client with that, when in fact, we have to recognize that that's a ripple effect of something very basic, such as, hey, if we fix your sleep, then all these other ripples, dissipate.
Melissa, I love that. I love that perspective.
And it's a critical thing, because, if you don't follow the ripples back to the core, like sleep, which you obviously demonstrate can affect so many factors, we're missing the point.
Yeah. Well, I think it comes when you think about Maslow's hierarchy of needs, right? When you think about that pyramid of biological needs have to be met first before you can get into goals. And it makes me think about when you have toddlers. When a toddler is cranky or they're picking a fight with another kid in the sandbox, the first thing we say is, are you hungry or are you tired? Right? And it's kind of like we need to do that to ourselves. Are you tired? Because if you're tired, that could actually be the reason you're having conflict in your relationship or having these other things, because you're tired, right? So maybe we can take an approach from our little ones and do a better job of thinking about that for ourselves. Yeah.
And the question that I had asked in regard to sound therapy, again, kind of to the neuroscience, neurofeedback side of thing, and understanding parasympathetic, sympathetic, well, the best place is in balance. One of the things that we look to is, rhythms in certain types of music can affect our brainwave frequencies. I use sound, suggested sound therapy with some of my clients where, okay, listen to this, and in 3 minutes you come to a calm state. Well, if you're, it's like, okay, so if you're integrating music before you go to sleep, or integrating what are you going to listen to if you wake up and you can't get back to sleep, what kind, I'd really like scientific research, evidential studies that say, this affects it in this way, or this is the best kind of pathway to go or not for, the correlation between sounds, which is another sense, and sleep.
Definitely. And I think that at least the research, and again, there could be a whole body of research out there I've never looked for, but I think the research on the guided imagery and the progressive muscle relaxation is really paralleled to sound therapy with sleep. And so I suspect even if there's not work specifically on sound therapy, you have a body of evidence that would serve as the foundation to say, this is a really good hypothesis, right? That these two are going to be.
I'm a high proponent of, I give progressive muscle relaxation exercises to most all my clients, because
I love that.
Yeah.
I love that. Yeah. When I do it in class, half my students, so when I turn the lights on, they're like, okay, well, now I want to go to sleep, Dr. Peach. I'm like, sorry. That wasn't my point. I wanted to relax you. Let's see. And I think I saw in the chat, somebody mentioned about never having a bedtime as a kid. And my mom and dad would say it was our right to rest. And yeah,
That
so
was
you
me.
bring, okay, yeah, that you bring up
Yeah.
two really, really good points. The first one, right, is this idea of bedtimes. And I think this culture really plays in here. Some cultures, you know, bedtimes for kids aren't the norm. Other cultures, it's very common to have a strict bedtime. But this idea of the perception or attitude of sleep that is influenced familially, right, by your parents, a lot of times we tend to take on the attitudes and the beliefs of our parents. And I think it's amazing that they said it was your right, something you deserved. Anecdotally, same thing for me. I remember being in high school and, you know, we would sleep so late. Now I understand why biologically. And my dad would always say, let him sleep. I can hear him saying that. My brother would be sleeping until 4 p.m. and he said, let him sleep. His body obviously needs it. Where I had other friends whose parents were like, get up, you're being lazy. You need to go to your tennis practice. And I think that that translated with me and the way that I value sleep. So I completely agree with you.
You know, I'm a psychotherapist, and in psychotherapy, we usually say that sleep disorders or sleep problems are usually the canary at the coal mine. You know, it's the first thing that goes away when your mental health is not there. So I go back to what my parents would do, you know, and it's like, as an adult, I know that when I'm not sleeping well, something must be wrong, because I know that I deserve it. You know, I know that my body, and it's so basic to just get to know your body that way, rather than I need to take medication, or I need to do something.
Right.
What's wrong with me? What's going on with me right now that I can even get myself to sleep is a better question. I think that would prevent a lot of other issues, you know, and a better way to get to know ourselves. And that maybe you don't have to use medication at that point, you know, so.
Yep, I completely agree. And I mean, I love that phrase of I deserve it. My body deserves it. Like, I just think that's such a fantastic perspective to have. And that, you know, it's a sign, like you said, if there's something wrong with my sleep, that's a chance to say, what's going on? Is there a physical ailment? Is there an emotional conflict? Something, this is an indicative of something, right, that's going on.
This is reminding me a lot about like viewing sleep as kind of like a performance behavior. And I wonder, Dr. Peach, if you kind of ran into the sort of counterproductive side of focusing so much on like sleep as something that I need to improve. And if I don't improve it, then I'm a failure, or I can't even sleep well. Like, I wonder if there is this performance element at times that you've run into, whereas sometimes not focusing on it, or as Elena's talking about, maybe it's, you know, less of an emphasis that actually helps you relax and sleep more. So
you actually hit the nail on the head. So there's advice that comes from sleep physicians, and this comes out of the insomnia, CBTI insomnia stuff, that if you've been laying in bed, and I think they give a rule of thumb for how long, and you're frustrated, you know how you get in your bed and you're like, oh my gosh, I've got 8 hours, I've been up for 30 minutes. So now I have to be, you know, and you have this whole dialogue in your head. They suggest that if you've done that for X amount of minutes, don't lay in bed any longer. They say, get up and go quietly, you know, in dim light, do something else, like read a book. And that if you continue to fight it, you're doing just that. You're almost like, oh, like I'm not performing correctly, and you have anxiety. So Kate, I think it's 30 minutes, she said, so that might be it. And they say, get up and do something quietly. And that is supposed to combat that idea of, right, of viewing it as a performance. Yeah.
Sasha, that rings true for you and your partner.
I am lucky to not suffer, but he definitely does. Yeah. Yeah. And I think it's like what you're describing, this sort of catch-22. Like, I need it. I can't get it. There's something wrong. I got to get it, because if I don't get it, then I'll feel sick, and just, yeah.
Yep. And I personally, I had to stop wearing a Fitbit because I did that exact same thing, Sasha. I would get up and I say, it said I woke up all the, you know, and I would have anxiety about sleep. I'm not performing well. And so I literally had to stop. And so now I go off of, you know, the subjective satisfaction, you know, my hours that I was in bed and my subjective satisfaction the next day. Yes. Yep. So true. There's so much self-care and self-love connected to sleep, you know.
So I know I listened to another talk one time, and it talked to the people who presented it talked about the lizard brain And they also, I suggested, like, if you wake up at 3 a.m. and you just can't fall back to sleep because of, and then you get into the anxiety you're talking about, that their suggestion was, think of your brain as a lizard brain. And so, eat a little piece of something that's sugar and some protein, so because if you put the quick sugar in, it'll dissipate the adrenaline that's running through your system because of the anxiety. And then the protein feeds the brain. And so it'll, within like 15 minutes, it'll dissipate that to a level of being able to go back to sleep.
That is so interesting.
Yeah. So, and it makes sense. But I recommend that to clients when they have problems sleeping. But again, it goes to correcting after the fact, as opposed to the stuff you talked about, which is the best thing to not get there in the first place. Right. But at least it's a treatment for if you do have that anxiety stuff going, so you don't spend the whole night just worry.
Right. Exactly.
You mentioned Fitbits, and I'm thinking about like the explosion of wearable technology, and just kind of the point you make about the subjective satisfaction versus the biological measurement of sleep is, I don't know, really fascinating, because I think a lot of folks that have a bent towards neuroscience or whatever like the objective element of it. And
yeah.
I've had many neuroscientists would say it's sometimes the best way to get data is just ask someone about it, and I think it's just a nice reminder that the bio designation is not the end of the story, and sometimes not even the most important part of the story.
Yeah.
So I think it's a really nice reminder, and I think that's one of the takeaways that I'll have. So thank you for reminding me of that, Dr. Peach.
Oh, I love that. And, that was one of the challenges when I first came into this field, and I'm trying to publish in, Journal of Sleep Research and, these major, very still bio-based journals. And they'd always come back, well, we need polysomnography. And, our argument was, one, that's just not feasible, to do when you're trying to look, in these college settings. But just like you said, Dr. Beeson, it's important, but it's not the whole story. And one of the approaches that we took in our lab was to get both objective and subjective measures of sleep where we could. Yeah. Oh, that's interesting. I'm going to copy that right now so I don't lose it.
Yeah. And we're actually we haven't done this always, Sasha, maybe we'll put this in our workflow, but saving the chat and looking up the resources afterwards so we can put it in the newsletters. So I think we'll start doing that a little bit better as the community continues to evolve. So we'll put that on our to-do list.
I love that. I know that's one thing whenever I give talks or even with my students in class, and I'm like, can you write that down? Can you email me about that? Right. And that way I'm always, learning too when I get to interact with folks and talk about these cool topics.
Yeah. Well, mindful of time, thank you all. I think great presentations generate more questions too. And I think that Dr. Peach, you both presented us with some really practical and wonderful information, and also encouraged us to ask more questions. Now we have some other research designs that we need to accomplish at some point in our lifetimes.
We got a to-do list now, guys.
Yeah. So
well,
I hope
thank you for having me.
Any closing words you would like to offer?
Just say, it was wonderful. Yeah. Again, I love getting these, I love to hear from folks in the clinical field. So, I'm on the teaching side and the research side, but I'm so just in awe of folks that get to work with one-on-one with patients. It's not something that I do. So I just think it's amazing the wealth of knowledge that you all have from working with these patients. And it's just, I feel like I get really good ideas when I get to hear what's happening, right, in these sessions and with these folks you work with. So thank you for sharing with me and for having me.
Yeah. And Sasha, who do we have next month? Do you remember off the top of your head?
I'm pretty sure it's Lisa Gunadian.
Okay.
But I should double check how to
Yeah.
pronounce the name.
Well, there's a teaser, and be ready, be on the lookout for the newsletter, and we hope to see you all again next month. Thank you all.
Bye, everyone.